This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin. This is the Healthcare Education Transformation Podcast. And this is one of your co-hosts, Brandon Powen. And of course, I am joined, as always, by my co-host, F. Scott Fiel. And today, we have a very special guest with us joining today, the one and only Mike Eisenhart. Now, Mike Eisenhart is a physical therapist who is an industry leader in health prevention and promotion. He serves as managing partner of Proactivity with over 15 years of experience in physical therapy, prevention, health and fitness, performance training, and healthy nutrition. Mike is also the founder of Free the Oak and also the Academy of Prevention and Health Promotion Therapies, or the APHPT. He is the man behind the Summer of Move craze that a lot of you might be seeing on Twitter and Facebook. He has held posts at the local, state, national levels for the APTA, including president of the New Jersey chapter from 2015 to 2017. He is a faculty member for the Institute of Clinical Excellence, where he teaches the Allied Health and Health Promotion course, which is a 12-week online course designed to equip the learner with the resources and network required to fundamentally shift their career towards preventative care in a profitable manner. Now, Mike, thank you so much, first of all, for your dedication to the profession, and as you've truly made a big difference within the realm of physical therapy with the health promotion and prevention avenue. And thank you so much for taking the time to talk with us today.
Man, my pleasure. Thank you. That was kind.
Yeah, Mike, that is some impressive bio, man. I know it was relatively all-encompassing, but is there anything that you'd like our audience to know about you that we didn't mention in the opening?
Ooh, no, I mean, professionally, you guys covered it. I mean, let's see. Personally, I'm the fourth of six kids, so there's a bit of a fun fact, I guess. I'll tell you a little bit about my personality.
So, Mike, do you think the solution for widespread health promotion and prevention for non-communicable diseases will come from the top down, or do you think more a bottom-up approach? And maybe you can touch a little bit on the community integrated healthcare system and the role it may play in the solution, for our audience.
Sure. So it's a great question. I don't think that it's going to happen necessarily one or the other. It's almost definitely going to be an and. No question we need some leadership, at the policy level. So that kind of top-down approach. We need to be able to find a way to create an environment that makes it easy to be healthy, right? So the healthy way is sort of the easier choice. And so we know there's lots of really great info on kind of environmental approaches, kind of setting up like an ecosystem and environment that succeeds. But it will definitely not be done without some sort of bottom-up effort. Really where the people are, and anybody who's kind of taken the course with me or has heard me speak hears me say that a lot, right? Go where the people are, because ultimately a big part of the non-communicable disease problem is related to health and healthy behaviors. Some people quoted as much as 40% of the problem. So if we can't make it conducive for people to live in a healthy way and also make it personally rewarding to do so from the bottom up, then we don't have a chance. So I do think it's kind of a both and type thing. As far as the integrated health systems, it's interesting because there's sort of this change in this evolution happening within the healthcare systems where insurance companies are becoming providers and provider groups are becoming insurance companies. And if that ever really integrates and we get sort of aligned incentives where everybody is really able to integrate both kind of vertically and horizontally, I do think that it can be a big part. Right now, not to sound cynical, but I don't think we're there yet in the large health systems. I think that they're still very much in a sort of sick care paradigm, sort of dealing with folks, kind of pulling drowning victims out of the river, as public health folks like to say. But we could get there. And I think that if we can find ways to make it a little more palatable, maybe even a bit more profitable to deal with people early and to keep them healthy, they might be a real good place.
Yeah, for sure. And you're right. You're totally right, Mike. In terms of right now, it seems like we definitely have more of a kind of an acute care healthcare model, really dealing with the problem until it's really, really bad. But, one thing that I found, Mike, that I've learned from you is about, the behavior of populations. And do you think you could kind of tell our audience a little bit about the phenomenon of population tipping and kind of along with, you kind of discussed with this before about how we need to make an impact at each level, but how do you feel that we could do that? Like, what would we need specifically within certain levels, or just kind of give an example of that?
Sure. Yeah. So, the idea of tipping a population is really, in a sense, it's moving the herd, right? It's getting the entire group to kind of change. So most people talk about the end point of that being kind of culture, right? So if you, and of course, I'm really not giving you a very technical definition here, but if you can tolerate culture being sort of group behavior, we always do it this way. This is just the way we do it around here. That's kind of our culture. Then you're ultimately trying to change that from one that is less than ideal or suboptimal to something that's closer to optimal. But there's some real nuance in going about that, right? So the long and short of it is that it makes mathematical sense to think of it as a scale, and you've got to kind of get 51% of people to do the new way, whatever that is, and then everybody else will kind of tip. But that's really not, so says the research, how it happens. A big part of it has to do with kind of catching the right people, the people who have, sort of leadership, whether that be, formal leadership by title or just influence, and bringing them along, and then kind of all the social dynamics that go with that. So, making it both the easy, low barrier choices, but also the cool and exciting and maybe rewarding choices, and kind of bringing people along. So in a sense, that's the thought of it. How to do it, there's of course lots and lots of theory, and there's, probably like 20 or 30 or 50 theories of how behaviors get set and how they change. And it's way beyond the scope of this to dive into it. But one of the real interesting ones is this framework of what they call the social ecological framework, which is levels, in a sense, based on how many people are kind of in the group. So you've got the individual, they're sort of at the heart of it. Then, slightly bigger than that, kind of the small group or maybe the family unit. Then you've got kind of, bigger than that, the institutional level. So things like the employers and institutions in the community. And then you've got kind of even bigger than that, the community level. And then finally, even bigger than that, sort of the policy level, kind of the societal level. And really what the theory and the framework suggests, and it's pretty high quality thing, is that you really need something at every one of those levels. You can't, expect to change society if you're dealing with only individuals. And you just never get there. You'll never have enough time, because you just can't have, you'd have to have almost a one-to-one for the size of the problem, which is, of course, for non-communicable disease, hundreds of millions of people. So at any rate, that's sort of the idea, is you've got to have different tactics at each layer of that. So the difference would be everything from like a soda tax at the societal level, or in New Jersey where I'm at, they just the governor just raised the smoking age to 21, right? So they've made it harder to do the unhealthy thing, and then further down, you'd have to go at every single level and have something. So that's where, in many ways, I think we're kind of missing. We have a pretty good individual system, the traditional healthcare system, and we're really starting to see some things at the societal policy level, but we've got these gaps in between those two.
Wow, Mike, great points. You used a lot of good words there that really kind of tied the whole message together. But influencers, I know, was one of them that you said, and I think we're seeing a lot of that with social media nowadays and how much of an impact that can make on things. But the other thing that you kind of mentioned was like, having all those levels and having them have almost like a synergy. There has to be individual work being done at each level, but then they all have to kind of come together too. So I definitely see how that can be kind of a massive undertaking. But that actually leads me perfectly into my next question, which is, in your opinion, what do you feel has been the most difficult part of advocating for population and preventative health to institutions or policymakers? And what have you found to be maybe the most successful tactics that you've seen in addressing it?
It's a great question. So the first thing I think that is difficult is, it's hard to make a very simple logical case that you can prevent something, right? So like if I do this, I did get that, or if I do this, I didn't get that, right? So how do I prove beyond the shadow of a doubt that if I did this action, I didn't have that occur, that bad thing happen, right? So that's a hard thing for people to wrap their brain around, and it's always been kind of a hard thing, regardless of the fact that we have huge banks of data that say, people who employ these specific habits don't have these terrible, nasty outcomes, or at least not anywhere nearly as frequently. So I think that's a hard thing. I also think it's very similar to the concept of how come people don't save more for retirement, right? Like the idea that, yeah, I'll plan for someday, that's kind of against our human nature, and you might even argue it's kind of against our, genetic experience, right? Like over years and years of like, I got to just get through today. Like I have to be aware, my nervous system is built for, get through today's struggle, detect today's threat and get through it, not worry about, years and years from now. So it's very much counterintuitive and maybe counter nature to us to think about doing something today, investing for the long term and kind of playing the long game. So I think that's been really hard. It's gotten easier though, right? As people start to realize the savings that they can have. And we kind of, in our practice, made a bet that, at some point down the road, it would just get so costly that it would be unsustainable not to at least try this, at least try to, kind of do something for prevention or investing in the future.
Yeah, we've got to be getting close to that point right now, right?
Well, it certainly seems like it. I mean, my gosh, you start talking about, I forget what it was. I think it was the Milliman Medical Index now says that, the average family of four is going to pay like almost $30,000 a year for healthcare. I mean, all said, like their employer is going to pay 15 and they're going to pay another 12 or something like this. I mean, who can do that? Like that's unsustainable. So at some point we've got to say, look, like we got to start trying something. I mean, so that I think is a big one. As far as, the successful tactics, I think making it human again has been really, really successful. When we stop and we kind of explain to people and say, look, we're all doing the same basic thing here. Whether you are a, rocket scientist, brain surgeon, or you're the guy who's, cleaning up the streets, we all have the same basic plan. We're all the same person. We want to work hard, make enough money to eventually someday enjoy it and be with our family and friends and have enough time to enjoy some high quality of life. Like I've never met anyone who doesn't have that basic framework. And that, look around. Like you're just not going to do that if you don't put some investment back into your health. So when you start kind of putting it in terms that people can understand, like, look, healthcare is the single greatest reason why people go bankrupt. Like you can't afford to be sick. Like it's just that, it's simple. Like you just can't afford this. All of a sudden now, people's eyes kind of widen and bells and whistles go off. So that has been one where I think making it kind of human and real and for us, in a sense, getting our kind of our very smart PT and medical colleagues out of our ivory towers and getting down to where the people are and just being real people and saying, look, we've got this really specialized knowledge. Let me tell you a story. It can be a happy ending or it can be a not so happy ending. You choose. That's been effective.
Yeah, Mike, and I think that's a great bit of advice for not just like population health, but I mean, even in the educational realm, right? Whether we're educating at a student level, at a patient level, or a coworker level, or a CEU level, like just being human and having those conversations and just putting it into context with stories and ways that people can relate. I mean, that really just seems to be probably one of the best methods of communication that I've heard through all of the episodes that we've had thus far.
For sure. So, Mike, granted, we know that every company that one would pitch to about health promotion and prevention is different, and we realize that the specific answer to this depends on a lot of different factors, but do you think you could kind of tell our audience about what generally one should aim to do to accomplish this during the pitch to be the most effective?
Yeah, and I certainly couldn't say that there's a science to this, right? I mean, there's some science to it. There's certainly some nuance, and you could dive in and say, well, there's some social science and some psychology, and and there's lots of great authors who are way more accomplished on this topic than I am. But I guess I would look at it. It's very similar to what we now strive for in creating therapeutic alliance in the clinic. Person walks in the door, your first job is to get on the same page with them and build some level of alliance or rapport where you can work together and solve the problem. I think if anybody who can do that effectively is never going to have a shortage of clientele, whether they're dealing with the individual in the clinic or they're dealing with, hitting a home run in the boardroom or like whatever it is they've got to do. Being able to kind of, align quickly and be able to say, I get it. I understand what you're wrestling with and what the implications are of it, of this problem that you have. I can't solve your problem. You can solve your problem with the knowledge that guys like me have. So we can come together on this and we can work together and get somewhere. I think that is the number one aim in any meeting where you're trying to get someone to sort of change. And in a sense, I mean, I know as healthcare professionals, we've always kind of shunned the S word, selling is like a bad word. But we're starting to realize, and of course I always point to Daniel Pink in his book, he talks about non-sales selling, to sell is human. And he actually specifically mentions physical therapists, which I thought was cool. That's all it really is. It's convincing someone that the current way they're doing something isn't yielding the result that they want. And that there's other ways of getting after it. And that we as professionals have the knowledge and know how to come alongside them. So I think that's really what you're doing. It's just understanding a different problem. So whereas many of my clinically based PT friends can, explain, tendinosis at a level that is just mind boggling, we are just looking at a slightly different problem and saying, look, like your problem is that bodies are just not up to the task. They're not living long enough or working hard enough or whatever the capacity that you need, you don't have. And that's going to cost you lots and lots of money if you don't try to fix that. And as a business, that matters. So it's a big financial problem. It's a big human value problem. It's a big culture problem. I mean, you're wrestling with a big deal here, and then diving into it.
Yeah, Mike, so kind of playing devil's advocate here a little bit, what are some of the biggest barriers that you see that are being put up by either companies or communities when we're trying to bring this issue up?
Well, I mean, the number one, of course, which for us is a little bit less, is, well, show me that it works. Like I hear wellness programs don't work. Is that what you're trying to sell me, a wellness program? And for us, we always kind of look at it and say, well, you could kind of broadly classify it that way, but I don't love that because in my mind, there's kind of an evolution almost of offerings. And the first offerings of something are very kind of scratch the surface, not really based in science. I talk about sort of throwing stuff at the wall, seeing what sticks. That level of intervention when it comes to keeping people healthy is not going to work, or it's at least going to not work as often as it does work. And so it gets very easy to say, well, how do I know this is any better than doing nothing? But what's happening now is that there's beginning to form a base of evidence, just like we do clinically, where we say, look, like there's a right way to do this. There's a dosage, right? So in general, we know physical activity of any kind will yield positive results. There's no rocket science there, but physical activity of this specific dosage can yield that specific result. And I think that's really where health promotion, prevention, population health, it's starting to get there. I think the other part of it is that, the complexity of this makes it sort of almost hard to comprehend. And so that becomes a barrier. Like, I can't even deal with this. It's just so much. And it is. I mean, if you really dive into what population health is, it's not as simple as just keeping the population healthy, right? Like we want to make it that because that's easier for us to comprehend. I mean, we're talking about all sorts of complex variables, and this is a complex system that changes, right? So you throw one thing at it, and now it's going to deal with that, and two other kind of variables pop out of place, and so it's getting the complexity kind of under control. And so I think that's also very hard. So, people often will look at that and say, I just can't afford that. Like, it's just too much money. Like, how could we do this? And of course, we'll push back and say, you're already paying for it and then some. You can't afford not to do this. I mean, at the end of the day, if you're a company today, you're in the healthcare business. I hate to say that, it sounds terrible, but like, I don't care what widget you make or what service you offer. Your number 2 or number 3 greatest expense is more than likely related to healthcare if you have any number of employees. So, you can either bury your head in the sand or you can start managing that well. And cost shifting, which they did 10, 20 years ago, which was just, let me just hit employees with more cost. That's kind of hitting its end. Like, we can't do that much more because you become less competitive as a company. People don't want to work for you anymore because your benefits structure is no good. So now what do you have to do? Well, you have to actually help them get healthier because that's the only thing that we know costs less, is simply not using the system as much or not needing to, which is kind of neat for anybody in this space, right? It's Doing something related to health is becoming almost a ubiquitous practice in companies that are of a decent size, right? So more than a couple hundred employees. And the reason why is for a couple of different reasons, right? One is to contain costs. I mean, everybody kind of wants to do that, but that's actually becoming less of the lever, right? The greater lever is, also they want to be competitive in the marketplace, right? So people are actually looking, as the new generation of workers comes in, they're looking for these kinds of benefits. Well-being is becoming a very important thing. So there's kind of this generational change that's happening, right? And I hate to always, everybody kind of wants to point to the millennials, but it really is a big factor they've got to deal with, right? So the world post World War II generation just, kind of wanted to work really hard and survive. And then there was sort of like that next group and the baby boomers who wanted a high quality life, but they also still kind of held that same belief of work real hard, make enough money, that kind of thing. And now the millennials are saying, no, my quality of life matters a lot, maybe even more than making a lot of money. So I want to work in a place that's rewarding, that has some of this. It's kind of built in, and that's making people change. And then finally, when you start to look at the greater picture, which is kind of the oncoming tidal wave, right, of metabolic health and specifically mental health, there's such a big impact on businesses when a person is not healthy from sort of a metabolic or mental health perspective. That again, they almost look, just help my people be a little happier. Let's just improve in general. Let's get people more engaged in their work. In a sense, that's how far gone the situation is, and that's very sad. But it also creates a pretty low bar, because more and more companies are saying, look, I got to do something. And if you have some evidence and you can walk in and say, look, like, don't do something, do something good, they're very happy to talk to you.
Yeah, it really is sad that it's kind of come to that point, but we're definitely seeing that in a lot of just disgruntled workers, across the country in all settings. And hopefully we can have an impact by, just making some simple changes, and as clinicians kind of using the best evidence to kind of help them work through some of those things. Mike, I'd like to change directions just a little bit here and ask, in your opinion, how do you think that the topic of population and preventative health should be integrated into healthcare provider education?
Well, so I'm certainly no expert in provider education in the sense of like all of the requirements and things. So my brain immediately goes, uh-oh, that's a CAPTI question. And I certainly don't know much there. But I would say if I had it my way, right? So if I can answer it that way, if like the world according to Mike, if I had it my way, I think it's foundational. I really think it's a fundamental knowledge base, a fundamental skill set. And I almost feel like it'd be great if it was like the first, like when I went to PT school, anatomy was the first thing we did, and physiology and like the basic kind of stuff. I would love to see health promotion, prevention, pop health type stuff as the basic, because what that would do, if it was our entry point to education, it would frame everything else we do looking through the lens of my job is to keep people healthy and out of the healthcare system, which is very different than, at least my experience so far has been, which is, yeah, we should do this. It's a bolt on, an elective kind of thing that happens at the end. And, it's a specialty. Like, oh yeah, if you're interested in that, here's a quick, hour on it. I think if we took that same 1 hour and just started it, it was the first thing that people were exposed to, it might frame it totally different. And then all of a sudden now they're thinking about, well, how can I use that therapeutic exercise not just to help somebody get out of pain, but to make sure it never happens again. And I think that's a very different view of the world. So
yeah, that's a great view on that, Mike. I think, looking back, I kind of the same thing with you. I took anatomy and physiology the first summer of PT school, and then beyond that, we got into a class that was called Intro to Patient Care. And I think if it was framed that way, in that even before we started anatomy and physiology, we started with maybe an opening, hour-long talk about it, and said, just keep this in the back of your mind as far as everything you're going to be treating in the future. But yeah, let's try to prevent some of these things. Let's try to think of ways just out of, kind of like a light undertone across the whole PT spectrum for those, 2 or 3 years, whatever PT school might be for you. And then maybe incorporate it into some of the intro to patient care classes and the communication classes and the psychology classes and things like that, where we maybe build on it as the semesters went on. But yeah, I definitely think that could be a great tactic for the future.
yeah, it would be awesome. I mean, I to whatever extent PT schools kind of almost get branded like, oh, well, this group has a very strong faculty in XYZ or, whatever it is. Like, this is, if you want to be a peds therapist, go here. If that kind of a thing was to happen and somebody stepped up and said, like, we're going to be known for putting out the best in prevention and promote health promotion and pop health type, like true on professionals who this is at the heart of what they do. I mean, that would be, oh my gosh, I'd want to.
Yeah.
Cough, APHPT, cough.
Well, that, I mean, listen, no doubt, but I mean, I'm even talking like entry level. That would just be awesome.
Yeah, definitely.
For sure. And programs could even use that as a pretty big selling point too. Because especially with, the issues that are facing with the finances and that with getting into DPT programs, colleges could be, the university could be like, hey, we offer this for that, just more of an incentive.
Yeah, that'd be cool. It'd be very cool.
Mike, we like to end each episode by posing this question to our guests. And if you could change one aspect of higher education, DPT or otherwise, what aspect would you change and how would you recommend that it's changed to that?
Ooh, that's a tough one. I mean, if I could change one thing, I guess, maybe we've hit on it a little bit. I would love for it to be, a little more health facing. I mean, that to me is probably the greatest glaring gap, that we start with kind of from the beginning, this idea of our job is to fix pathology and not necessarily to help people be the best version of themselves. And, and I know there's some purists out there who probably don't agree with that statement and wouldn't agree with it. But I think there's a lot of stuff that we could kind of, again, if I had it my way, we could dump, just some things that it seems to me. And again, it's been a while since I've been a student in PT school, but it seems to me there are things that are getting taught because they're on the test and not because they're being used day in and day out or are the kind of crux of our practice. And I mean, I'm a bit of a pragmatist, I guess. Like then why? Like, let's get rid of them. Then change the test. Like we've got to figure out a way to dump that stuff so that we can put our time into what's really high priority stuff. And I just think that non-communicable disease, chronic disease burden, it's the plague of our time. I mean, it's the most pressing thing that we are dealing with day in and day out. Our comorbid conditions and non-communicable disease. And if we don't start making that a priority, we are missing the big stuff.
For sure. No, I think that's a good point, Mike. And kind of something even too, granted, I'm not an education expert by any means, but even so, looking back on my education, I'm like, what if we just take some of the time that we spend on modalities like ultrasound and e-stim and all that time, and why don't we just significantly shorten it and focus on more community-based like health in this issue and even finances, and just incorporate that time with other things that are maybe a little bit more relevant in the real world?
Yeah, I agree. I mean, I don't think it would be hard. And again, I don't know, so I can't say this, but it just seems like with the technology that we have today, it would not be hard to make some of those things a flipped classroom. Like you're doing right now, right? You're educating people in a format that they can do asynchronously whenever they want to listen. Great. Like, okay, remember the ultrasound unit will be on the test, so study it up. We're not wasting our valuable time on it. So, listen to it and might want to listen to it twice because it will show up, but that's all you got to know.
Right.
I mean, like, again, I'm completely simply making something simple that isn't simple, which probably isn't fair. And some of my academic friends will be upset with me, but
we'll allow it.
It's all welcome.
Well, Mike, thank you so much for coming on the podcast to chat with us tonight. Always enlightening when we get to talk to you. Can you let our audience know where they can find you online and on social media?
Oh, totally. And I appreciate that. Thanks. So online, best place to find me these days is probably through some of the APHPT work. So it's mike.eisenhart@aphpt.org. That's my email. On Twitter, I really like Twitter, except when we're all arguing about silly things. At Mike Eisenhart, all one word. No spaces, no underscores. And, I'm on Facebook and a little bit on Instagram through Free the Oak, but I would say Twitter, email are probably the easiest. And of course, Ice Physio with the course for the CERT APHPT.
Awesome. Thanks again so much, Mike. And one last question. Where do I get a pair of those hot Free the Oak socks?
Those are on hot demand, no doubt. So those were 2016 issue. So I got to see. I have to see if we can redesign something for 2017. So I can only tell you at this point, stay tuned. More good stuff coming.
Nice.
Awesome. Very cool, Mike. Thanks again so much.
My pleasure. Thanks, guys. Great work.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.